Okay, so the topic for the moment is dysrhythmias. I'm probably going to do this presentation in a couple of different recordings. I don't think I'm going to do this all in one sitting, but we'll see how it goes. Dysrhythmias are abnormal, disordered, or disturbed rhythms. They're caused by a disorder that changes the electrophysiology properties of cardiac conduction or muscle cells. These changes can produce a change in either the automaticity, namely the ability of the heart to generate its own impulse, the conductivity, the ability of the conduction system to actually transmit, or both. There are a wide range of causes for dysrhythmias. Examples are listed here. General, whoops, hopefully you don't see that. Somebody just sent me an email. I'm not sure if that pops up on the recording or not. Anyway, back to causes of dysrhythmias. General hypoxia, as would occur in someone who's got chronic lung disease or who is in shock, can also affect oxygenation of the heart and can produce dysrhythmias. Then you can also have more local ischemic changes, as in coronary artery disease or angina. The sympathetic nervous system can be implicated, producing catecholamine release. Sometimes if you get very nervous, your heartbeat races. Certainly if you exercise, that's an appropriate response. The tachycardia would be an appropriate response, but sometimes in certain situations, exercise can produce a disturbance in rhythm. Heart failure, because of the sympathetic nervous system stimulation that occurs when the heart muscle isn't contracting and providing for the body. And then hyperthyroidism. There are a variety of drugs that can produce rhythm disturbances, and you can see them listed there. I might mention that anti-dysrhythmic drugs are in and of themselves pro-dysrhythmic. So, sometimes that can be problematic. Electrolyte disturbances, and when we consider the conduction system of the heart or the heart muscle, we're particularly concerned about potassium, calcium, and magnesium. Bradycardia, not as the rhythm disturbance itself, but sometimes if the heart rate drops too low, of course that is a dysrhythmia, or can be a dysrhythmia, but then as a result of that lowered heart rate, sometimes you can get an escape rhythm, namely some part of the heart decides it can do better than the slow beat that's being generated in the conduction system, and so you might end up with an escape rhythm. Stretching of the myocardium, as occurs in heart failure or hypertrophy or in valvular disease. And then cardiac tissue injury, as would happen in a patient who has a myocardial infarction or who has an inflammatory change, or sometimes post-cardiac surgery, the irritation to the heart tissue can produce dysrhythmia. So now let's see if I can find my pencil. Okay, if we look at the essay node, I'm sorry, I'm trying to make this tool thing work. I don't think I want yellow. Let's see if I can change the color. Yeah, let's do that. All right. The essay node is somewhere in here. Then you have intranodal pathways. Here's the AV node. Here's the AV bundle. Let's see if I know my right and my left. Here's the left bundle branch, the right bundle branch, and then you have Purkinje fibers that kind of carry you through the heart muscle. Remember those. Remember also that these various movements of electricity through the conduction system produce segments on your ECG tracing. So for example, the P wave is representing the depolarization of the atria. So from the beginning of the BP to the beginning of the QRS is the time that it takes the impulse to get all the way through the AV node and to start stimulating the ventricles. The ventricles then produce your QRS complex. Okay, clinical manifestations. So what's the big deal? Clinical manifestations can range anywhere from none, totally asymptomatic. Those generally happen with a benign dysrhythmia, as would occur. I don't like my blue pointer. Let me see if I can do better than that. I wonder if I can change the color. That's a check mark. I don't want a check mark. No, smiley face. I'll work with that. An example of a benign asymptomatic dysrhythmia would be a first-degree heart block, and we'll talk about those down the road. If the dysrhythmia compromises cardiac output, you might have symptoms of syncope. The patient might have palpitations, and the awareness of that palpitation can actually cause anxiety. Myocardial ischemia can produce tachycardic rhythms, heart failure, and then sudden death can produce cardiac arrest. Types of dysrhythmias. Well, sinus problems. Here you have the impulse formed in the sinus node, but it's irregular. An ectopic problem, the rhythm disturbance is formed outside of the sinus node. So it's not originating where it should. Conduction problems, here the impulse is formed correctly, but it doesn't transmit through the conduction system the way it's supposed to. And then you can also have something called a pre-excitation problem, like a short circuit in normal conduction. And what that then allows is for the impulse to go the normal route, but while it's going the normal route, it also comes across and comes back up and re-stimulates. Kind of a short circuit thing, kind of goes round and round. Some tachycardias work that way. All right, now that we look at some of these rhythms, let's try this. Here's normal sinus rhythm, and you guys have seen plenty of those now. P, QRS, T. The first thing I notice as I look at it is rather regular. It seems that the R to Rs are pretty regular. Every P has a QRS, every QRS has a P. You know, each complex looks like the last complex and looks like the next complex. Normal sinus rhythm. Sinus bradycardia looks like a normal complex. The only difference here is that the space between one complex and another is longer. If you were to actually count the little boxes, 5, 10, 15, 20, 25, 30, 35, maybe 36. And you divide that into 1,500, and that would give you the heart rate. Now, I do notice that in this situation, this is a sinus bradycardia, and the PR interval is normal, so it's not more than 5 little boxes to the best of my eyeballs. So it's truly a sinus bradycardia. The SA node is just firing more slowly than you would expect or than it should be. Is this a problem? Well, I guess I'd go check on my patient. Just because I see this on the monitor doesn't mean that my patient is having a problem. Maybe he's sleeping and his heart rate is just slowed down. Maybe he's an athlete and he doesn't need to generate an impulse any more quickly than this. So when do we concern ourselves about sinus bradycardia? Well, we have to ask, how's the patient tolerating this? If the patient is symptomatic, then we will intervene. And the intervention is really for any symptomatic bradycardia. This, what we looked at, was a sinus bradycardia, but you can have bradycardias that are not sinus. I did say that sinus bradycardia may be normal in some people, and the symptoms may be related to a hemodynamic decrease in cardiac output, which drops the blood pressure, which could make a person lightheaded or dizzy, or can aggravate heart failure. So the interventions: atropine, 0.5 to 1 milligram increments, up to 3 milligrams IV push. After 3, we've pretty well loaded the body with the parasympatholytic, and we're not going to get any additional effect. Remember that your cardiovascular system is, pretty healthfully, in a good way, under sympathetic nervous control, and the parasympathetic, via the vagus nerve, kind of regulates that heart rate, like the reins on a horse that I mentioned before. So to keep your heart rate normal, or to keep your heart from racing away, the reins on the horse are kind of pulled tight. Well, in a bradycardia, you want to loosen those reins to allow the sympathetic nervous system to take over. And that's what atropine does. Atropine reduces the parasympathetic effect and then allows the sympathetic nervous system to take over. If that doesn't work, then we use dopamine or epinephrine, and we do those in infusions. And the dosage is the same in either instance. It's 2 to 10 mics per kilogram per minute. And if that doesn't work, then we are going to set up for a pacemaker. Now, sometimes we just go ahead and set up for the pacemaker. It's not necessary for someone to fail dopamine epinephrine before we put a pacemaker on. One good reason for that is you have to have IV access for these, and especially for epinephrine, for dopamine also, central line is preferred. And sometimes before I can get all that in, it's just easier to put the transcutaneous pacemaker on the patient and go from there. We will talk more about pacemakers later. This is sinus tachycardia. Again, you've got a normal PQRST, PQRST. They look pretty similar all the way across. It's a pretty regular rhythm, but if you were to count, that's 5, 10, 12. So, 12 into 1,500 is more than 100. The assessment of sinus tachycardia is we have to pay it a little bit more attention than we might sinus bradycardia, in the sense that the patient may or may not be having symptoms, but even if they're not having overt symptoms, sinus tachycardia may still need to be addressed. Now, if I'm on the treadmill and I'm tachycardic, I'm fine. We don't have to do anything about that. But if I'm in the ER and I'm having a heart attack, and even though my sinus tachycardia might not be adversely affecting my hemodynamics, having tachycardia in that situation can increase my cardiac infarction size because the tachycardic rhythm requires more oxygen in a situation where I'm having trouble with delivery. So, that's one example of a situation where we want to slow that heart rate down, even though the heart rate itself isn't producing the primary problem. Some other reasons that we might want to consider addressing sinus tachycardia is it can increase or decrease blood pressure depending on the impact that it has on total cardiac output. At some point, initially tachycardia can be a compensatory thing to keep your blood pressure up, but eventually if my heart keeps going faster and faster, what I lose out on is the ability of the heart to fill, because tachycardias impair the diastolic time, cut into the diastolic time, and the diastolic time is that time when the heart would be filling in order to have blood there for the next beat. So when that happens, when you decrease your ventricular filling time, you may end up decreasing blood pressure. The other thing that you do when you decrease your ventricular filling time, remember that at the same time that the ventricles are filling, the semilunar valve, in particular the aortic valve, is closed and the coronary arteries are being filled passively with blood. You need that diastolic time for the heart muscle itself to get its oxygenated blood. And if my heart is beating very, very fast, those coronary arteries do not have the right amount of time to fill, and when the ventricle is contracting, it's actually squeezing blood. Of course, it squeezes the blood in the coronary arteries every time it contracts, but if you're doing that, right after another, then you're not allowing adequate perfusion time of the heart muscle. Again, if I'm on the treadmill and I'm jogging and I'm getting my heart rate up like that, I shouldn't have chest pain. I shouldn't have a problem with that. Generally, when we talk about these problems of ventricular filling time impacting coronary artery flow, we're usually talking about a patient who's already got some impairment in their coronary arteries. Causes, well, increased metabolism. A fever, hyperthyroidism, those would be some things that could increase metabolism. Medications, catecholamine, caffeine, cocaine. And then you must always think about the potential that the tachycardia is compensatory. Before we just slow down someone's heart rate, we want to make sure that that heart rate is not necessary to maintain the blood pressure. For example, if my patient is very dehydrated and they're tachycardic because of dehydration, and I give them medications to slow their heart rate down, their blood pressure is going to tank. So what you need to do is assess the patient's situation, what is making them tachycardic, and maybe rather than slowing the heart rate down, we should fill the tank. Get fluids on board. If you get fluids on board, the tachycardia will subside on its own, if that's the reason. There was another example I had. Heart failure. The patient who has heart failure, if they're tachycardic trying to compensate for the heart failure, what I probably need to do is address the heart failure primarily and not just give medication to slow the heart rate down. So that's here under treat the underlying cause. You can have the patient, if the underlying cause has been addressed and we really do want to break a tachycardic rhythm, we can have a patient do a vagal maneuver, like have them bear down or have them cough very hard. And then we can do beta blockers. Esmolol IV is an IV beta blocker that we use continuous drip. We use labetalol IV push, although it also has big alpha blocking properties. Metoprolol, we use that, another beta blocker. And then calcium channel blockers, the predominant calcium channel blocker that we use in tachycardic rhythms that need to be slowed down medically is deltia's MIV or Cardis MIV. Okay, we're still looking at sinus node problems. And one I don't think your book has is called sick sinus syndrome. And it really is just what you see. It is a sick sinus problem. The SA node is not working right. And because that happens, you can see significant bradycardia, you can see sinus arrest, or you can see escape rhythms, and then it might alternate with a tachycardic rhythm. So I've got some examples here of sick sinus syndrome. For example, here, this kind of looks like an atrial fibrillation, and then suddenly the heart, and by the way, this just means that you don't see all of the strip, and then the sinus node doesn't work at all, and now we've got an escape beat. This is a sinus arrest down on the bottom here. P, QRS, T, P, QRS, T, and then nothing. Okay? The thing about sick sinus syndrome is it can look just lots of different ways. Both of these slides are sick sinus syndrome. In this one here, look, you have a very tachycardic rhythm, and then all of a sudden a lot of nothing. And then you can see over here how irregular it is. It's like the sinus node just doesn't quite know how to act. This beat right here isn't even generated by the sinus node. I don't see a P wave. Now this one I see a P wave. So the sinus node's not acting right. Look down here. You see multiple examples of the sinus node just failing to be right. In sick sinus syndrome, your patient may experience syncope, and it may happen very suddenly without warning. I have a friend of mine who was having this issue. She found herself, she was driving her car, and thank goodness she was on a side road, because the next thing she knew, she was facing the opposite direction with traffic kind of coming towards her. They took the car to the shop and had it all checked out. You know, was there some kind of a gas leak that, you know, made her not be right in her head? You know, they did an extensive car workup. And then eventually they got to working her up and found that it was her heart. And her heart rate was dropping very low at times, and then it would speed up. And in those times of dropping low, she wasn't getting blood flow to her brain. Anyway, the intervention for sick sinus syndrome is always a pacemaker, because your heart is just not reliable. And then if the patient has tachycardias, we can use medications to control those. All right, we are going to talk about heart blocks next. Heart blocks. Let's start with some simple concepts. All heart blocks have something to do with a problem in the AV node. If you look at these 4 heart blocks, there is first degree, there's 2 different second degrees, and there's a third degree. The first 2 are not particularly serious. The second 2 are definitely serious. So, in a first degree heart block, there's no change in hemodynamics. The only thing that's different is the PR interval is prolonged. So here's the P wave, and see how long it's taking the impulse to get through the AV node? Now, as you look at this monitor strip, you do see that it's very consistent. P to QRS is consistent every single time. So every time the SA node fires, the impulse goes across the atria, gets to the AV node, and eventually gets through to depolarize the ventricles. So that's what makes it first degree. Every P has an associated QRS. Every QRS has an associated P. The only change is that it's taking longer to get through that AV node. You know, think of it as, you know, the AV node is like the door to the ventricle, and it's just taking the owner a while to answer the knock on the door. One of the things that we should think about is that most factors that produce a first degree can also produce a second or a third degree heart block. So as long as it's a first degree, we don't have a problem. But if it progresses, then it can be significant. So there's a wide range of meds, certainly beta blockers, calcium channel blockers, and DIG, and sometimes, you know, multiples having a beta blocker, a calcium channel blocker, and DIG altogether can be enough to promote a first degree heart block. Now, from your perspective in the clinical setting, you're not going to be able to tell that someone has a heart block by checking their pulse. The pulse is very regular. The rate is very regular. You see it on EKG. A heart block a first degree heart block would be worth mentioning or paying attention to if the patient never had it before, and we've got a variety of medications on that could be impacting that. Coronary artery disease, myocardial infarction, especially if we're talking about the inferior MI, because the inferior MI is caused when the right coronary artery becomes occluded, and the right coronary artery supplies the AV node in most people. Very high potassiums can cause heart block, as can acute rheumatic fever. All right, the second degree. There's two different kinds, Mobitz type 1 and Mobitz type 2, and just keep them in order. You know, the second degree type 1 is not dangerous. The second degree type 2 is. So if you just learn your heart blocks in order, first degree, second degree type 1, second degree type 2, third degree, you'll be fine. In the second degree type 1, each stimulus has a more difficult time getting to the AV junction than the last. Finally, a stimulus doesn't make it through at all. Then you have a relative recovery, and in the AV junction, a relative recovery of that AV junction, and the whole cycle starts again. The second degree type 1 is almost always transient. Again, it can have the same causes as the first degree. It usually is rather intermittent and generally not problematic. The way that I imagine this is, you know, there's a knock on the door, and the old man gets up to answer the door, and then he goes and lays back down. There's another knock on the door, and he's tired. It takes him a little longer to get to the door, but he opens it, and then he lays back down. The knock on the door again. He's not getting enough rest. It takes him even longer the third time to get to the door. He opens it, you know, lets that impulse through. That's what I mean when I say he opens the door. And he lays back down, and then there's a knock on the door again, and he's just too darn tired to get up and open the door. So that impulse just doesn't make it through because he didn't open the door. Now that he's rested just a little bit more, with the next knock on the door, he can jump right up again and get there. He goes to lay back down, knock on the door, takes him a little longer to get there, knock on the door even longer, next knock on the door, he just can't handle it. So in a strip, this is what it looks like. Let's start here. The SA node fires, and the impulse gets through the AV node. The door opens, ventricles conducted. This time, the SA node fires, and notice the PR interval gets a little longer. Takes that old man a little longer to get to the door, but he opens it, and the impulse gets through the AV node and fires the bundle branches. The next time there's a knock on the door, but the door doesn't open. So there's no QRS. You know, the old man just kind of slept through that one. So then the cycle starts again. The SA node fires, and it gets through, The SA node fires. It takes longer, but it gets through. The SA node fires, and that impulse is stopped. Then the SA node fires again. So, as you glance at this strip, you should notice that the pulse is irregular. This is, if you're feeling a radial pulse, you're going to feel this beat, bump, 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 bump. Okay, with an irregularity there. When you measure PR intervals, you will see that they are not the same. Progressively longer until there's a missed beat. If I look, I see I actually have more P waves. Oops, there's a P wave without a QRS. So I have more P waves than I have QRSs. And of course, P waves by themselves do not allow blood to flow out of the ventricles. Okay, you got to have the QRS to get the blood to flow out of the ventricles. The second degree type 2 is rarer, but also more serious than the type 1. It generally means that the conduction system is quite diseased. It's usually not transient. It's usually not related to meds, but you can see it with digitoxicity. A person with either this heart block or the complete heart block, which is coming next, they need permanent pacemakers. Now, in this kind of a heart block, what happens is the SA node has to fire several times until before the impulse actually makes it through the AV node. So kind of the way I picture that is the old man is a tired old man, and the SA node, knocks on the door, he ignores it. The SA node knocks on the door again, he ignores it. Finally, the SA node knocks again, and he goes, oh, all right, and he gets out of bed, and he opens the door, and the impulse comes on through and conducts through the ventricles. Then he goes back to bed. He got up at once, and now he's tired again, so he ignores, or just doesn't open the door because he can't. So this is what it looks like. What you will see if you measure out the P waves, if you take a piece of paper and you measure the distance from this P wave to this P wave, and from this P wave to this P wave, and from this P wave to this P wave, you will find that the P waves are quite regular. But at least half of the P waves do not have an accompanying QRS. At least half, and sometimes more. In this case, it's more. So P wave, no QRS. P wave, no QRS. P wave, finally you have a QRS. By the way, it even took longer to get through, but it did. Then here's a P wave, P wave, P wave that does conduct through. Now the problem with this rhythm is in the rate. I mean, I don't know how well I'd be able to count by fives doing this one. I'll just make it rough. 5, 10, 15, 20, 25, 30, 35, 40, 45, 50, 55. So, from here to here, of course, I'm not doing a good job counting, but there's 55 to 60, okay, divided by 55. That's a heart rate less than 30. That's going to impact cardiac output. And here, let's look down here. P wave, no QRS, P wave, QRS. P wave, P wave, P wave, P wave, P wave, P wave. Now, I don't know if I think there might be a P wave in there, in that T wave. P and T conducting together, I really can't tell. If I were to map this out with paper, I would expect that there is a P wave in there, buried with the T wave. Again, you've got a heart rate problem. 5, 10, 15, 20, 25, 30, 35, 40, about 45. 1,500 divided by 45, that's a heart rate of 33. So certainly this is going to decrease cardiac output, decrease blood pressure, so you can have symptoms of syncope, and you can have myocardial ischemia, because if I'm beating that slow, there's not enough blood. Yeah, there's plenty of time for the blood to bathe the coronary arteries, but you know, if my heart rate's 30, it should have bathed my coronary arteries 3 times in that same amount of time. And or it can cause heart failure, because if I'm beating that slow, then my heart's not emptying and it can back up. This strip here, actually, let's look at it. This is sinus here. Now, this is not a real pretty strip, because see the QRS? There's actually a little bit of a rabbit ears here, so there's some blockage in the bundle branches, but it is getting all the way through. So you got P, QRS, T, P, QRS, T, P, QRS, T, P, QRS, T, P, QRS. Now look what happens. P, no QRS. You've got a complex there. You've got a complex there. So it goes from sinus rhythm to a second-degree type 2 heart block. And it's a second-degree type 2 because whenever I do have a PR interval, the PR intervals are just like the last ones. PR intervals are all fine when I have them. But I have more Ps than I have QRSs. The Ps are extremely regular. Okay, the SA node is firing with great regularity. It's just that in this situation, every other beat is not making it through the AV node. Now, in a third-degree heart block, there's no communication. The AV node does not conduct impulse to the ventricle. So the SA node fires. That impulse gets to the AV node and just stops. So what happens is, because of the automaticity properties of the heart, if the ventricle's not getting the impulse that the SA node generated, because it absolutely doesn't make it to the AV node, then another bit of tissue in that conduction system below the AV node will pace the ventricles. Of course, anything that's below the AV node is going to pace more slowly than the SA node can. Remember, SA node can do, 60 to 80 to 100. The high AV node can do, 45. When you get down to the lower side of the AV node and into the ventricles, you're looking at 30. So what you see here, we'll look at it in a minute, but the atria is getting its impulse and contracting, getting its impulse and contracting, getting its impulse and contracting, and the ventricle is getting its own impulse and contracting, getting its own impulse and contracting, not at the same rate because ventricles are slower. Remember the conduction system below the AV node. If you get a new pacemaker down there, and when I say a new pacemaker, I don't mean surgical. I mean if your body decides that it needs to allow additional tissue to serve as pacemaker, the ventricle pacemaker is going to be slower. So, third degree can be transient or permanent. You do need a pacemaker if you have this. Stokes-Adams syndrome is a Brady dysrhythmia that causes syncope. So the heart rate drops low enough that the brain doesn't get good flow, and yeah, you just need a pacemaker. Heart rate drops, cardiac output drops, blood pressure drops, and organ perfusion becomes a problem. So that's your syncope piece here, and then the decreased forward movement of blood can produce an acute decompensation in heart failure. In a third degree, the rate of the ventricle, which is the rate of the ventricle, is what correlates to the pulse you can feel. The ventricular rate is 30 to 60 beats a minute, depending on where the block in the AV node is and where the new pacemaker has set up. Atrial rate will be faster. Now, in this scenario, the P waves are all present and they are regular. The QRSs are present and regular, but they're less frequent. So if you just eyeball this strip here momentarily, you see QRS, 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 QRS. Now I look at that and I go, that's pretty regular. If I were to count the little boxes from here to here, it's slow, but, same distance. Now I'm looking for my P waves. Oh, wait a minute. What's going on here? Where are these P waves? Now to do this, you almost need a piece of paper, And you take that piece of paper, and let me see about getting a writing utensil. Not black. Let's see. Let's make a different color. All right. So you get a piece of paper, and you march out from one P to the next P. All right. So that's from there to there. And then, so I have to imagine this. So from here, I do that again, about that many boxes, I could count them. And you know, there's probably a P wave in here. There's probably a P wave in here somewhere buried along with that T. It's kind of hard to tell. Now here's a P wave, and if I were to go back the same amount of distance, I don't know. You know, you march these out. You take the piece of paper, and of course I can't do it as good as I could in class. Maybe I'll have to do this in class for you. You march out, but what you find, you know, if you do this in a way that is doable, you find that the distance from one P wave to the next is consistent, and then you use that consistent thing to imagine where additional P waves might be. See, that could be a P wave buried in the T. The point is that the P waves have no relationship to the QRS. They're just not related. You know, you can make a case that on the strip they look related, but honestly they're not, because even if the P wave happens to fall in just the right place on the ECG paper, that impulse didn't go through the AV node, and it was just by chance that it looked normal. You know, for example, let me see. In this strip I don't even really see one that looks normal. Like this P wave here is really way too close to do much good. But you know, it could be that there'd be a P wave right here, but it would be by accident. This is really a nice looking strip because everything's mapped out for you. You see how regular the P waves are across here? Perfectly, beautifully regular. And here's the QRS, perfectly, beautifully regular. And of course, the P wave rate, the atrial rate, is higher. Look, there's a P wave in the QRS. There's a P wave right at the end. And then the PR intervals are all varied. And what you need to realize is that while you can physically measure the PR interval in a third degree heart block does not represent the amount of time it takes the impulse to get from the SA node to the AV node, because none of these impulses are getting to the AV node. The fact that you have a QRS at all is because somewhere below the level of that block, another group of cells have taken over to allow this to happen, to allow this to happen, to allow this to happen. So while you can take the strip and you can measure that, right, you can also know that the PR interval is a sham, okay? Because the PR interval really implies that it's taking this much time for the impulse to get through. And in this scenario, this impulse, this P wave, the impulse that created this atrial depolarization never got through to touch the bundle branches. Here's the strip. This is one of mine, actually, one of my patients years ago. Let me see if I can see it. Yeah, 1995. 1995. So I marched out the P waves. And here, it's a second degree type 2. And then it went into a third degree heart block. Okay, you got all these P waves. They're beautiful. And actually, I must say, the ventricular rate is pretty fast. 5, 10, 15, 20, say 24. Yeah, the ventricular rate is about 62, and that just tells me that the new pacemaker is sitting fairly high in the junction in this situation. But look, PR interval. PR interval, crazy PR interval. I mean, you know, I can measure these PR intervals, but these intervals do not represent the amount of time it's taking that impulse to get to the AV node, because none of these impulses are getting to the AV node. So what do we do? Let's talk about heart blocks in general. What do we do for heart blocks? Well, we first of all, I need to cough, excuse me. So I cut off the recorder for a minute so I could cough. Interventions. First of all, we intervene in heart blocks when the patient is symptomatic, or if it's a second degree type 2 or a third degree. And keep in mind that with the second degree type 2 and the third degree, the ventricular heart rate is typically low enough that the patient will be symptomatic. So first of all, we identify and remove cause if we're dealing with a symptomatic AV heart block. All symptomatic bradycardias will get atropine. Dopamine and epinephrine is another group of meds, and we infuse that at 2 to 10 mics per kilogram per minute. And then pacemaker, you know, we'll start with the transcutaneous. That's the skin. You know, we put pads on and we allow the pads to act as a pacemaker. And then a little bit more stable than that is a transvenous pacemaker, where they put a wire through a vein and let it sit in the heart, and then eventually the patient can go for a permanent pacemaker. And who needs pacemakers? Well, all symptomatic bradycardias that are not responding to the atropine or the dopamine epinephrine infusion, or all second degree type 2 and third degree heart blocks. We don't mess around with those. You can use atropine, dopamine, epi while you're waiting for the pacemaker in the second degree type 2 or the third degrees, but that's, you know, that's going to be what that patient needs. You know what? I think this is probably a good place for me to stop. I wonder how long I recorded. I'll do some of this a little later. We will start up again with atrial dysrhythmias in my next recording.